Legal. I'm a professor of medicine at the University of Ottawa in Canada, and I'm the current chair of INNoVTE, the International Network of Venous Thromboembolism Research Networks. And as you can see here, we are a partnership of 10 national VTE research networks, gathering over 450 investigators on multiple continents. And our aim is to support and promote collaborations to produce relevant, high-quality academic VTE research worldwide. These are the current network members, and we do have a representation from Australia, and then North America, Asia with China, and Europe with several countries, as you can see on the list here. The seminar series is something that this is the second iteration of the seminars. And what we want to do is to feature some inspiring research initiatives, inspiring studies and examples of collaboration across the network to make these studies possible, but also highlight how by doing these studies or by setting them up, we can have a chance to improve some research standardization or some definitions or some collaboration tools between each of us. And I want to acknowledge the contribution of Sanofi through an educational grant for making these symposia possible. And so today's presentation will be featuring the HIGHLOW study and a new definition of postpartum hemorrhage. And we'll have 3 speakers today: Saskia Middeldorp, Laurent Bertoletti, and Bernard Tardy. And so we will keep the question and answers at the end, and you can use a dedicated function on the Zoom to ask your questions. And again, we'll do that after the 3 speakers will have presented. So our first speaker today is Saskia Middeldorp. She's a professor of medicine and head of Department of Internal Medicine of the Radboud University Medical Center in Nijmegen in the Netherlands. And prior to being in Nijmegen, she was a professor of medicine at Amsterdam University Medical Centers for several years. Her research, as I'm sure most of you know, is on some hereditary acquired thrombophilia, women's history in thrombosis and hemostasis, clinical evaluation of new anticoagulants, and she has been the principal investigator of multiple practice-changing trials, particularly ALIVE, ALIVE 2, and HIGHLOW that will be discussed today. Of to mention, she's also the immediate patch chair of the INNoVTE network. Saskia.
Thank you so much, Grégoire, for this introduction. And it is my true pleasure to speak about one of my 2 trials that are now in such an exciting phase of their execution. And this is about the HIGHLOW study. And I think it is an excellent example. I hope to inspire you with it, to show you that collaboration is necessary to provide answers to relevant clinical questions. And this is all about venous thromboembolism in pregnancy and the prevention thereof. So I have some disclosures that may be relevant to this talk, but all the support and fees are going to my hospital so that I can actually use those to bring forward academic research. So I'm going to speak a little bit about the prevention of pregnancy-related venous thromboembolism, then a little bit of rationale of the HIGHLOW study, and then how progress and networking are closely intertwined in this particular example of an investigator-initiated randomized controlled trial in a, let's say, difficult population. Not that the women are difficult, but it is difficult to do research in pregnant women in general, I think. So just to set the scene, we still know that pulmonary embolism is a major cause of maternal death in developing countries, with 2 to 3 per 100,000 births complicated by a mother who dies around childbirth. A real disaster, of course. During pregnancy, deep vein thrombosis occurs more often than pulmonary embolism, and also can have very dramatic consequences because of the proximal location of pregnancy-related deep vein thrombosis, and because of the long-term impact in terms of post-thrombotic syndrome. Overall, VTE rates are listed here. It's about 1 to 2 per 1,000 women, with a rate that is lower during pregnancy and higher postpartum, and much higher than in non-pregnant women. But in absolute terms, because the antepartum period, of course, is much longer than the 6 weeks postpartum period, approximately half of all VTE related to pregnancy occur during pregnancy, and the other half occur in that shorter postpartum period. So this is when once women have it. But in general, we do know that we'd like to prevent this. And this slide is a slide about women who are at increased risk for VTE related to pregnancy or postpartum. And I think in general, this is a very old slide that I transformed for this webinar because the HIGHLOW study goes a long way back. But I think this hasn't really changed. So first of all, we should consider prophylaxis based on absolute risk during or after pregnancy. And this, of course, can be women who have never suffered from VTE, like carriers of certain thrombophilias, or women with a strong family history, or women with transient risk factors during pregnancy. But I think importantly for this talk and for the HIGHLOW study are those women who are at highest risks. And those are the women who have a personal history of venous thromboembolism, whether it was related to pregnancy or oral contraceptives or other circumstances. So this is the target population for the HIGHLOW study. What we knew when we started thinking about the HIGHLOW study, which is about 10 years ago, was that the risk of pregnancy-related recurrence was quite high. About 6% estimated from cohort studies, relatively small cohort studies, if you didn't provide these women with antepartum or postpartum prophylaxis. And just to give you an idea, the Brill-Edwards study was 125 women, and then we have Pabinger and De Stefano, and also a very, very modest number of women, less than 200. What we also knew at that time was that there was probably an influence on the recurrence risk of thrombophilia or estrogen exposure during the first VTE. And we also were pretty confident that there was a very low risk of recurrent VTE in pregnant women who had their first VTE elicited by a major risk factor and without thrombophilia that came from the Brill-Edwards study. Also unresolved were the dosing of low molecular weight heparin. And at that time we had the ACCP guidelines on the pregnancy chapter that I was also a co-author on, and the ACCP guideline advised prophylactic or intermediate dose low molecular weight heparin to prevent recurrences in pregnancy. This was a grade 2C recommendation, meaning that it was a very weak recommendation based on a low level evidence. And what was also done was that the relative risk reduction of low molecular weight heparin was extrapolated from orthopedic surgery. And we all know that if you give prophylactic doses, that you only get about 64% relative risk reduction. I think this is something that is a very important thing to realize. And I think that people outside our field not always realize that you do not prevent all thrombosis with prophylactic doses of low molecular weight heparin. So at that time, several treatment failures on low dose low molecular weight heparin had been observed by myself personally and also published from our group, but also from others. These treatment failures, so to speak, occurred antepartum and postpartum and were up to 8% in high-risk women. And this evidence was highly criticized, also because, first of all, it was observational, there could be publication bias, and of course, as is the case in many retrospective observations, things like adherence to medication were not very well recorded. Now, as a clinician, I was also quite impressed by the side effects of low molecular weight heparin. And you can see three forms here that I've shown over the years many times. In the upper panel, let's say very mild but annoying itching around the injection sites. On the left, lower panel, it's a hematoma that is not dangerous but scares many patients, and it's also a nuisance because, for instance, clothes do not fit very well or hurt because of the hematoma. And very rarely, I should say, is the woman on the right lower side with a type 1 allergic reaction, which is actually the most worrisome reaction. But those skin reactions of any type are really present in 20 to 40% of the women. Then, of course, there is the nuisance of the daily injections in general. There is a reason to be concerned about bleeding. And of course, there are implications around delivery with increased bleeding risk and also the ability to undergo an erectual anesthesia. So I was thinking, and we were thinking at that time, that it was quite annoyed. We don't know what's the best dose, and we are imposing a, let's say, burdensome treatment towards women with, for instance, like 9 months, even 10 months of injections, and the relative risk reduction is only 64%, with a residual risk of about 36%. And we don't know how high that risk is because all the data are being criticized. So that is when we designed the HIGHLOW study, and it's a very simple study on paper. The objective was to assess the efficacy and safety of intermediate dose low molecular weight heparin versus low dose low molecular weight heparin in pregnant women with a history of VTE. And we hypothesized that this intermediate dose is superior in preventing recurrent VTE with an acceptable safety profile. And not only on paper, but for instance, also in the Netherlands, it was not so difficult to get, for instance, ethical approval or to have patients provide informed consent because both of these doses were in the guidelines at that time. So this is the study design. As you can see, very, very simple. Women had to have a history of VTE, be pregnant, be randomized prior to 14 weeks, and the earlier the better. And we would simply count the outcomes of recurrent VTE and safety, major or clinically relevant non-major bleeding, including postpartum PPH, with a primary endpoint at 6 weeks postpartum and a follow-up until 3 months postpartum. And if any of those events would occur between those times, they fall into the secondary outcomes. So how did that go? Let me just go back. If you want to read more, in 2016, we published the rationale and design of the HIGHLOW study, a randomized trial of 2 doses. And in this paper, also the outcomes are being described, and of course, also the evidence that is being summarized by myself just now in 2 or 3 slides. Importantly, we had a problem, of course, defining a proper sample size, because we didn't really know anything about the relative risk reduction between an intermediate and a low dose of low molecular weight heparin. We assumed that there would be a 4 to 5%, let's say, so-called breakthrough incidence in the low molecular weight heparin group. And well, we just took the 65%. We didn't know whether or not that was right, but we tried to do so in order to get an event-driven sample size. And we calculated that we needed 29 VTE events. And you can see on this slide with the incidence in the low dose group here, you would come up somewhere between 850 and more than 1,200 patients, depending, of course, on how right we were in our assumptions. And of course, this is also always driven by feasibility. At that time, we had 9 network members, and I just wanted to show you this because I think it is really important to acknowledge the importance of INNoVTE, and I will show you in just a minute why that is the case. This is, I think, very nice example of how INNoVTE also not only supports trials, but also gives very nice recruitment updates. And this is at a time when we had recruited 75% of our patients. Here we go. I'm just going too fast. Sorry about this. So I think the animations are not entirely right. I just wanted to show you that in the first 2.5 years, and that is not on this slide, we were able to include a little bit over 100 women, 10% of our goal after 2.5 years. So if you would just simply go on that pace, we would still be doing the trial and my hair would be grayer than it is even today. Another 1.5 years into the trial, so after 4 years, we had been able to engage INNoVTE. That was crucially important for our study, and was able to get funding also from their French Ministry of Health. And later on, also the Irish network contributed. And at that time, after 4 years, we were halfway with almost 500 inclusions. We thought we were halfway, of course, because we weren't entirely sure about the eventual sample size. After 7.5 years, we had reached the event-driven sample size. We now have included a little bit over 1,100 women in 7.5 years. And if you just consider that the first third part of this study took us for 10% of the study sample, I think it really proves that you have to be persistent. And I think this is one of the challenging parts, that if you have funders that are very strict and they want you to meet the deadlines, I try to inspire you by saying just be persistent and try to do everything you can to get into this steepening of the slope of recruitment, because as you can see, since then everything went on very steady. But this was at the end with 8 countries and more than 70 centers. What is the current status? Well, I'm very excited. The final queries are currently being resolved and the database lock is imminent, and the ICAC, and you will hear more about that soon, is very, very busy. And what we have learned during this trial, I think is going to be spoken about by my next colleagues, who are crucial for the execution of the HIGHLOW study, as are all the investigators and women who have been included. Just very shortly, how will the HIGHLOW study affect guidelines? So when we designed these studies, we were at the 2012 VTE guidelines at that time by the ACCP. And this has basically, well, I cannot say that maybe out loud, but I will do it anyway, taken over with a similar group of authors by the ASH, and the 2018 guidelines with the same evidence basically have gone through different syntheses, because this is what the current evidence synthesis says. Antepartum prophylaxis, and this is compared to no antepartum prophylaxis in pregnant women with prior VTE. They estimate the recurrence of VTE with prophylaxis very similar to the iteration in 2012, but based on observational evidence that came out later and was published by Mark Roger, one of the founders of the INNoVTE, you can see that with antepartum prophylaxis, there is an estimation that there is fewer major bleeding antepartum and even fewer major bleeding peripartum. And this is coming from smaller trials in another indication in pregnant women that may not have counted the bleeds as critically well as we are doing that in the HIGHLOW study. And very similar for the postpartum prophylaxis, similar data. So I think even though these are evidence-based guidelines, this shows the limitations of the current guidelines because of the limitations in the evidence that we have. And the current recommendation, and this of course is after the start of the HIGHLOW study, is that there is a suggestion against intermediate dose low molecular weight heparin prophylaxis compared to standard dose. And I'm very happy that this synthesis of the evidence was not in the guideline at the time when we acquired the ethical approval for the HIGHLOW study, because this would have made our life a lot more difficult. So what do we know about low molecular weight heparin dosing? Even in a non-pregnant population, we do not know much. There is one meta-analysis, but this is about intermediate low molecular weight heparin versus no prophylaxis. And this study came out after we started, or this is a meta-analysis that came out just a few years ago. Very small studies. This is in acutely medically ill patients. And you can see that the relative risk reduction against no prophylaxis is in the same ballpark. So we may as well be wrong with the HIGHLOW study in the pregnant setting, but there's only one way to find out. So The HVT guidelines, the same ones that I alluded to, 2018, actually do explicitly say that more data are required regarding the optimal intensity of prophylaxis in the antepartum and postpartum setting. And I'm very, very happy that we hopefully can contribute to high-level evidence with this study. So I'm going to finish. All women with a history of VTE need postpartum low molecular weight heparin prophylaxis for 6 weeks, and most need antepartum prophylaxis as well. And this is the target population of the HIGHLOW study. The dose is uncertain, but we will provide answers, hopefully this year. Thank you so much, and I'm giving the control back to you, Caleb.
Thank you very much, Professor Middeldorp. So our next speakers now will be Laurent Bertoletti and Bernard Tardy. So Laurent Bertoletti is a professor of medicine at the University Hospital of Saint-Étienne in France. His research focuses on the management of vascular diseases, particularly pulmonary vascular diseases. He's a co-coordinator of our French INNoVTE network and the national coordinator for the HIGHLOW registry in France. Since 2021, he's the elected chairman of the PE Assembly of the European Respiratory Society. And Bernard Tardy is a professor of therapeutics at the Saint-Étienne University Hospital as well, and has been also in charge of the intensive care unit at Saint-Étienne University Hospital. And his research focuses on vascular disease, but also heparin-induced thrombocytopenia, thrombotic thrombocytopenic purpura. And so, well, I will let you both tell us the story of how you got involved with HIGHLOW and what was your next steps and contribution for us all. Thank you.
Thanks, Grégoire. Thank you very much for the invitation to participate to this very interesting webinar. So my name is Laurent Bertoletti. I'm the head of the vascular department and chest physician. Well, usually I have previous to say that I do not have any potential link, but in fact, as Saskia told, I'm a member of the ICAC committee, and it's a plain job. So maybe this is a link of interest. To start with a very simple thing, you know that randomized controlled trials are gold standard for providing good evidence. And for example, in the setting of this patient, if you want to know if treatment A is more efficient than treatment B, you can provide with a randomized controlled trial. And we know that randomized controlled trial in double-blind manner is the best way to provide the best level of evidence. And for example, we can, at the end of this trial, set the primary efficacy outcome, and at the end of the follow-up to see that, for example, A seems more efficient than B in this setting. We can also use the safety outcome to provide information about the safety of the procedure. And for example, in this setting, we will have the information that A seems as safe as B. Unfortunately, sometimes randomized controlled trial may be compromised regarding their results, and this is particularly true when we work with open label design. For example, if we keep exactly the same intervention, exactly in the same population, we know that an open label design may lead to an overestimation of the efficacy, but also may impact negatively the safety evaluation of the intervention. And it has been very well illustrated by Jeanne-Chloé Traune and Sylvie Laporte in our group with meta-analysis of all the data regarding vascular events in patients with cancer receiving anti-angiogenic therapies. And for example, if we look at the results in terms of adverse drug events in randomized controlled trial, you can see that regarding venous thromboembolic events, if you stick only to trials, open label trial, you will record an increased risk of VTE in patients receiving the intervention trial, anti-angiogenic therapy, while if you focus only on the data provided by randomized controlled trial in a double-blind manner, the other risk of VTE completely disappear. And it is also the same thing regarding another safety outcome, which was bleeding. If you look only at open label trial, you will have a huge increase in the bleeding risk in patients with intervention group. Anti-angiogenic therapy will be associated with a more than 3 times higher risk of bleeding. But if you focus your analysis only on data obtained via double-blind trial, you will see that, okay, there is an increased risk, but this increased risk is lower than if you only look at open label trial. So clearly, we have to stick in mind that open label are usually more easy to propose to the patient, but we have to remember that even for the adverse drug events declared in the trial, we have to be very aware that the data may be frail and misunderstanding in this setting. And so the trialist, I have proposed to develop what we call a probe design. You obviously know this design, and the probe is mainly supported by the existence of an adjudication committee. The adjudication committee will need all the monitored data, and this is very important. The member of the adjudication committee must be blinded to the location arm. And then the adjudication committee will assess the events notified, but also have the possibility to look at the files and sometimes to provide unnotified events, and will correct the events which were notified by the investigators of the open label trial. And this is also true for the safety outcome, where the adjudication committee may also correct the event and declare undeclared events. And so for adjudication committee, you have to remember that, okay, it increases the costs, it needs expertise, and I would like to emphasize the S at the end of expertises, because we have to be very complementary in the ICAC committee. But it also provides us an harmonization and a standardization of the event notified. And it has been always demonstrated, for example, in the acute coronary syndrome, that existence of an ICAC will completely modify the final results you will provide. And it is clear that in the field of pregnant patients, an ICAC will be very, very helpful, because this is, again, as Saskia told us, more difficult to provide good evidence in this situation. And this is particularly true, sorry for the typo in the police, for the safety outcome, because you will see in the presentation from Bernard, then sometimes the events would have 2 definitions, one provided by WHO and the other provided by the ISTH, for example. And sometimes it may be very, very difficult to have 2 different conclusions for the same event if you look at the WHO definition or if you look at the ISTH, for example, definition. And then I will add that ICAC may help to solve clinical dilemma like this one and increase the quality of further research. And I am really convinced of that. Bernard.
Thank you, Laurent. And I will let Bernard then take over for Tardy. Bernard, you're muted, so you will have to unmute.
Okay, can I have my slide, please? Thank you. Before starting, I would like to tell you that within our research team, we have created for a few years a team focusing on the adjudication of clinical events. In this team, we try to improve the evaluation criteria, especially when they lack homogeneity in their definition, such as, for example, death related or not to PE. You can see on this slide the main studies in which this team was involved. So, next slide, please. Thank you. So when we were asked by Saskia to manage the education committee, we look at the literature for the definitions of PPH. We perform a systematic research of clinical studies evaluating heparin in pregnant women. And then we select all reporting a randomized study comparing heparin to a placebo or to aspirin or to no treatment, and in which heparin was given at least until the 32nd week of pregnancy. We selected 16 studies out of the 57 identified. This 16 study involved a group of near 2,700 women. Of this 16 study, and while women were treated at least until the 32nd week of pregnancy, follow-up until the delivery was reported only in 9 studies, and the clear definition of major PPH was given only for 16% of the women included. Next slide, please. As you can see on this table, it is now up to date. It is impossible to have a fairly precise idea of PPH frequency, since the 2 studies reporting major PPH, as shown by the blue arrows, did not use the same criteria, and whose reporting minor PPH, as shown by the red arrow, do not always describe the criteria used. This explains the difference, for example, in the frequency of minor PPH from one study to another, with a rate of 5, 20, and near 30%. Next slide, please. As these different studies did not provide us any information to define PPH, we studied the recommendation from the different national society in this field. We found that there was no consensus to define PPH. Some societies retain 500 millimeter regardless the mode of delivery, as shown by the green arrow, and other retain on 1000 millimeter in case of cesarean section, as shown by the blue arrow. And finally, some define severe versus non-severe PPH, depending on the volume of blood loss, is shown by the purple arrows. If all societies took into account the volume of blood loss to define PPH, all agree in the same time that the visual estimation of this volume is totally unreliable. Some societies suggest the use of tools to measure the blood loss, such as the bag collectors, but these tools are not validated up to date. In the same way, there is no consensus regarding the blood loss volume threshold to treat or not PPH, as shown by the black arrows. Next slide, please. The only fairly conceptual point concerns the blood transfusion, which is guided by clinical examination and not by the drop of hemoglobin level, and whose objective is to maintain an hemoglobin level between 7 or 8 and 9 grams. Next slide. So concerning PPH, we were confronted with the absence of consensual definition. Should we define PPH according to volume of blood loss, according to a fall in hematocrit or hemoglobin level, or based on an a priori need for intervention? All these options are totally debatable, but and do not reflect the habits of everyone around the world. But at the same time, maybe this data can be complementary to establish a stratification of the severity of PPH. Next slide, please. From a pragmatic point of view, concerning the definition of PPH, there is actually no reason to propose a different definition between vaginal and cesarean deliveries, because the maternal health impact related to blood loss is exactly the same. In a situation where there is no visual means or techniques to quantify actual blood loss, the amount of blood loss reported may be not the only determinant of the severity of PPH. Consideration of the different means used to stop bleeding should further stratify the level of PPH severity rather than a dichotomy between severe and non-severe PPH based on the volume of blood loss. Next slide, please. So therefore, whatever the volume of blood loss, if not therapeutic intervention is necessary, it has to be considered as a minor event. If an hemorrhage or bleeding requires a first line of treatment with uterotonic to stop, it should be classified as a clinical relevant non-major bleeding. And finally, whatever the volume of blood loss, if a transfusion of 2 units of red cell is necessary to maintain an hemoglobin level more than 7 grams, we can consider this event as a major bleeding. Next slide. A first classification of PPH was established by a first working group composed by obstetricians and specialists in vascular and intensive care medicine. And then this classification was modified by after discussion with a second working group composed by hematologists, cardiologists, and specialists in vascular medicine. And the final draft was proposed to the ESTH subcommittee on control of anticoagulation. And again, after discussion and modification, we were able to propose to GTH a final draft. Next slide. You can see the final table, which was published in GTH 2 years ago. In this classification, we have included the different PPH treatment modalities within 2 volumes of blood loss, and we define 3 levels of severity of bleeding: major, clinical relevant, non-major bleeding, and minor. This way allows to not give an overweight or underweight to visual estimation of blood loss. And as you can see, a blood loss of more than 1000 millimeters can be considered as minor in the same ways as a blood loss lesser if the event do not require any therapeutic action. In contrast, a blood loss less than 1000 millimeter can be classified as major, for example, if the bleeding requires a transfusion. Thank you for your attention.
Thank you, Bernard. So we'll open now the question and answer sessions. So don't hesitate to use the Q&A function at the bottom of your screen. And I will start directly. We already have a question here for Professor Middeldorp, asking about published recent data with fondaparinux in pregnant women. Any thoughts on the place of that product in women not tolerating low molecular weight heparin?
Yes, I think that's a question that comes up a lot of the times, particularly because this small pentasaccharide is reported to cross in minor amounts the placenta. There's one study by Carl Dempfle quite a few years ago where he found these amounts in cord blood after delivery. So what the guidelines actually say is that you try to avoid it. But of course, if you have gone through all the low molecular weight heparins and you still have an indication, I do use it, and there are some reports, also small series, also from the Netherlands, showing no, as far as you can of course say that, no, in small numbers, no adverse effects. So I think in general, if you can avoid it, particularly in early in pregnancy, I would. But I have no problem using it with a good discussion, of course, about these small uncertainties.
Thank you, Professor Middeldorp. So again, don't hesitate to type your questions in. Maybe while we wait for more questions to Laurent. So as you say, right, when you were doing the work with the adjudication committee, anything else that you want to highlight that could be of interest to the group in terms of challenges or difficulties or ease of use of these definitions?
Yeah, thanks for the question. After the experience of the HIGHLOW ICAC, I think that preparing an ICAC is as far as difficult as preparing a CRF when you want to build a trial. I mean by that when you think about the CRF you will build for your trial, you are thinking about all the questions you will have and possible difficulties you will have during the trial. And I did not expect that the same extent of work would be needed when you will prepare the creation of the ICAC, because all along the life of the ICAC, new questions are raised, and this is very, very difficult. So in the future, it will be clearly very anxious or well preparing the first ICAC meeting and the definition of the ICAC, because clearly this is really, really, really important, and you can't come back, or it is very difficult to come back once you have started to adjudicate the event.
Well, thank you, Professor Bertoletti. I think that's a key message, right? And if to all the early career investigators around the table or in the assistant today, I think that's a critical point. And certainly we are also, willing to help with that. That's one of the things that INNoVTE wants to do. So I think if you are planning on setting up something like that, don't hesitate to reach out. We're happy to connect to people who have done that before and people who can help you paying attention to some specific details or paying attention to who should be around the table and all what it entails, right? Sometimes, we are all excited about writing the protocol, getting the money, and all these DSMBs and adjudication committees are like, oh yeah, we'll figure that out later. And as you say, I think it's very important. Professor Middeldorp?
Yeah, so I totally agree. I think that's a very valid point. And I think what we have learned from this experience, and I would also like to ask Bernard and Laurent what they feel, because at the time we were discussing this, I mean, you were at the ICAC and we had in the protocol just the ISTH criteria on non-surgical patients. And we had on the ICAC also obstetricians like Professor Céline Choleur. And so I think that is where it all became a novel field, right? And I think that is also important. And one of the things I'd like to highlight is that this has been set up because it had, well, as Bernard has clearly shown, it wasn't done properly in other trials. Even my own first trial, the ALIVE trial, we just, you know, I don't think we just did something there because the outcome was something else. And I think it also highlights the difficulties in PPH in general. There is just simply no consensus. And if you want to evaluate anticoagulants in this field in a proper way, I think that is where you really brought the field further. And I just wonder whether people will adopt it as well. I don't know what you think, but I hope, of course, that we are setting a standard. But people may just feel it a bit silly that if you lost 2 liters of blood, it will be classified as a minor event, whereas they are so used for on WHO history that it's going to be something severe. So I think that is still quite. I'm wondering what your thoughts are there.
Bernard, do you want to address that one?
I think it is very difficult to imagine a blood loss of a large amount of blood without clinical sign and without the need for a therapeutic intervention. So in practice, many doctors have the trend to minimize or maximize that they thought. And when we look with attention the fields of the data, we can better measure the reality of the severity of the bleed. And by combining the need for treatment and the volume of blood loss estimated by the clinician, we are probably we can probably better estimate the real impact of the bleed, I think. And for me, it's probably it could be probably a problem for the convector platform. Maybe I'm not sure, but if you using your platform, you have to judge the severity of the bleeding only with the data reported by the clinician. You could have some problem. For example, we receive a lot of PPH event, but in fact it was not PPH. It was blood loss related to episiotomy and not to the delivery. It's not. It's strange, but clinicians could report sometimes absurd things, totally absurd. In the same way, some report major PPH because they observe a decrease in the hemoglobin level based on a first evaluation of hemoglobin performed 3 months ago. So yeah, it's crazy. Yeah. And we have many examples like that.
I think it will make a beautiful sub-paper later on, I think. Yeah. Yes.
And so now what you're saying, so definitely, you know, for example, for the platform, the next step is to set up the definition within the platform, right? That's something that certainly we should be doing. As there is a question in the Q&A about that as well. Maybe maybe Laurent, you can take that one, is someone asking, well, as an ICAC member of a probe trial, how many times did you have to go back to the charts to extract these unreported events, and how did you decide that, oh, okay, I don't have enough information on what's provided here, you know, I need to look further, because that's exactly what you were discussing there now as well, right?
Yeah, and I do not have the exact number of time, but I think that the ICAC request to the center was very, 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 very frequent. Bernard, 1 in 3 times maybe we asked. Because this was crucial, and in particular in this trial. And yeah, clearly it is very, very frequent when you build an ICAC. And this is crucial to have a good way of communication with the coordinating center of the trial and then with the centers, because you will ask to the centers to provide you with information of patients, for example, included 1 year before. And this is very, very important if you want to adjudicate properly all the events. This is crucial.
Yeah, well, thank you for sharing that as well. And yeah.
For example, I can give you another example. Sometimes a clinician report a clinical relevant non-major bleeding because the patient receive oxytocin. But in fact, the dose of oxytocin was a current procedure and was only prophylactic and not curative. And it's totally different. And you have to ask the center to have the draft of the delivery, reporting the delivery, to know that.
And I think, but you know, again, that highlights how important it is to set up the rules before, right? Because as you were saying, well, sometimes you wonder why they reported an event, but you know, as an investigator, I always prefer to over-report. So as long as you don't tell me, don't do that, I would keep saying, well, better for them to decide whether it's as they want to qualify that as an event or not. Good. We also have some questions more directed to Saskia. Well, first question is a burning question. Is there any time where the data of the HIGHLOW study will be released?
Well, depending, of course, on the wonderful work of the ICAC, but we are actually hoping to be able to start data analysis in just a few months. So, well, we have ambitions that I'm not going to share because this is being recorded, but it should definitely be this calendar year.
Oh, very good. Great. Congrats in advance. And there is another question that's for you as well, Professor Middeldorp, about, you know, are all the low molecular weight heparin similar, or do they behave differently in pregnant women? That's a common question as well.
Yes, I think wonderful question. First of all, I don't know if they behave differently because, of course, we haven't seen the outcomes yet. This was a pragmatic trial and multiple countries. So many different low molecular weight heparins have been used. We have also dedicated a good discussion towards the variance or the, let's say, inability to simply trade one dose of low molecular weight heparin towards the other one. So there are some differences, particularly in this study, in how an intermediate dose has been defined. And of course, we can only later on in exploratory analysis see if there are any differences. But I think for clinical practice, we have also in this study different, so for instance, France used enoxaparin, Ireland used tinzaparin, Netherlands nedroparin, and I think at the end of the day we will have a good spread, and of course this is more or less, let's say, a geographical randomness in many of these women. So I don't know, it's not randomized between the various low molecular weight heparin, so it will always be exploratory and observational, but hopefully so. It's in my clinical experience, I don't worry much about one over the other. I think there are differences in tolerance and preferences between patients.
Thank you. I think we are arriving at the end of the questions in the Q&A. Laurent, you wanted to say a few words about you know, other aspects of the ICAC as well?
Yeah, thanks, Grégoire. One of the things I learned thanks to Saskia and the HIGHLOW study, what for the clinician and the investigators, maybe the the trend to report events is more higher in prophylaxis studies than in acute treatment studies I had to use to in HIGHLOW. Because if you provide a patient with prophylaxis, you will want to protect them from eventually an event, thrombosis, but you know that you will expose them to an adverse event. And clearly, I am convinced now that for all the prophylactic studies, ICAC is clearly more important than a lot of other committees, clearly. And regarding the question on underreporting, as we said some minutes ago, we also saw a lot of events which was not reported by the investigators when we look at the queries, because we had access to the charts. And in cardiovascular studies, it has been reported that a good HICAC may impact on about 30% of events by rejecting some or creating news.
All right, thank you. Very good. So I think we are arriving at the end, and thank you all for participating. Thank you to our wonderful speakers. I think we had a very interesting and engaging discussion today again. Thank you to our sponsors as well, and you can see them here on the slide. And we hope to see you all soon for our third international seminar. Thank you very much, everyone.
Thank you too. Bye-bye.